So,
Perfect.
good evening. It's a pleasure to welcome you to our ESDS webinar on a very timely topic, operate or irradiate in borderline resectable stage 3 non-small cell lung cancer. I think it's a situation which we're frequently faced in the tumor boards with discussions, and there's still a lot of opinion, and we will see what data are available actually on the topic. And it's a great pleasure to have highly esteemed faculty today with us. First, we have Ramie El Shafie. He's the Deputy Head of Radiation Oncology in Göttingen, and he will present us the radiation oncologist's point of view as the first one. Thereafter, Alex Brunelli, I think in this round needs no introduction, and he will present the surgical point of view. And Kristof Cuppens, who is the head of medical oncology in Yesser Hospital in Hasselt, Belgium, he's going to present the medical oncologist's perspective. So we're very much looking forward to the presentation. As always, if there are any questions or discussions, please write them in the chat or in the Q&A tool, and we will have the discussion once all of the presentations are finished. So, Rami, the stage is yours. We're looking forward to your presentation.
Thank you very much for the invitation and for the kind introduction. I'm sharing my screen. Are the slides visible?
Yes,
Perfect.
works
Okay.
perfectly.
Perfect. So good evening to everyone. I'm very excited to be here and talk about the radiation oncologist's point of view to this exciting topic. And I've felt so free as to slightly modify the title and put the IO in here, because I think that's a very relevant aspect, and especially regarding potential synergies between chemoradiotherapy and immunotherapy that we have been discussing at some length during the past years. And that's an exciting topic that I want to touch on in light of this overall discussion. So these are my disclosures, and if anything, we have been finding out during the past few years that stage 3 lung cancer is much more complex than we had imagined, and that the question of the optimal treatment, especially for borderline resectable non-small cell lung cancer, is a very complex and multifaceted one. And that is why, in discussing this question with you, I want to highlight basically 3 major aspects. I will start with the dream team that we've been talking about for many years of radiotherapy and immunotherapy. And we're going to look at the question if that still holds, is this principle still true? And we will look together at the current evidence for definitive radiosystemic therapy, but also at studies from recent years that have brought maybe 1 or 2 setbacks. And we will discuss the possible explanations for these setbacks. And the key issue here revolves around the topic of immunologic toxicity. And based on what we have learned from this explanation, we will then turn to potential ways of developing new approaches in stage 3 disease with the integration of radiotherapy, especially and particularly in borderline resectable patients. So let us begin with the much discussed synergy between chemoradiotherapy and immunotherapy. And this all began with the Pacific trial, which you all know, which was published some years ago. It showed us that if we give durvalumab consolidation after platinum-based concurrent chemoradiotherapy, we can achieve a significant and durable improvement in both progression-free survival and overall survival. And based on this synergy that we observed between chemoradiotherapy and immunotherapy, there didn't pass much time until the Pacific 2 trial was launched. And the idea was no longer to only test this strategy sequentially, but also concurrently. In other words, immunotherapy was given already during chemoradiotherapy. And the results of this study could hardly have been more different than expected. So not only the progression-free survival and overall survival were negative, but also even the response rate, and not only even compared to the Pacific regimen, but compared to placebo. And this shows that apparently the simple fact of giving immunotherapy concurrently with chemoradiotherapy may actually negate the established benefit of subsequent consolidation. And this was not the only study with such findings. Here we see the similarly designed checkmate 73L in non-small lung cancer with nivolumab, showing a very similar and likewise negative outcome. We have seen similar results in small cell lung cancer as well. So the NRG Lung 005 trial with atezolizumab, concurrent and sequential to chemoradiotherapy, again, a negative trial. And a possible explanation that has been discussed a lot since then is the role of so-called immunologic toxicity. So what does that mean? Well, the first indications of such a phenomenon came from the PET-PLAN trial, which was a trial in stage 3 non-small cell lung cancer, where PET-based radiotherapy planning was used to omit elective nodal irradiation and restrict treatment to definitely involved nodal regions only. And this was combined with isotoxic dose escalation. And interestingly, in the PET-planned arm, where radiation volumes were substantially smaller, tumor control and specifically local control was actually much better. It was almost twice as good. So the obvious question here is, how can that be? How can smaller radiation volumes achieve better local control? And one explanation that emerged from this observation was that with smaller treatment volumes, less radiation dose and less scatter dose reached immune competent cells and circulating blood in the irradiated area. This led to the development of a calculation model to quantify this effect, and it is called EDIC. So EDIC stands for effective dose to immune cells, and the formula that you see here looks much more complicated than it actually is. In essence, it estimates the radiation dose delivered to immune cells based on the mean heart dose, the mean lung dose, and the dose to capillary blood, which is estimated via the mean body dose. And this is combined with several weighting factors, and in the end, you get a dose with a gray value that shows us how much radiation dose is delivered actually to the immune competent cells. And this calculation model has since been validated in a number of thoracic entities, starting with non-small cell lung cancer, based, for example, on the data from the RTOG 0617, which was the large phase 3 dose escalation trial, but also, for example, in esophageal cancer. And what I'm showing you here is data from our own group, where we were actually able to analyze 250 patients, in this case with small cell lung cancer in the limited stage. And we were able to identify a clinically relevant dose cutoff at around 5 gray, which if we supersede in terms of the EDIC, then patients have a significantly worse PFS as well as OS. So what do we learn from these data, and how can we transfer this to the setting of borderline resectable non-small cell lung cancer in stage 3? We know that the mediastinum is the site of primary lymphocyte priming when immunotherapy is added to the equation. And it appears that when a toxic radiation dose is delivered concurrently with immunotherapy in stage 3 to these immune competent cells, then the resulting immune response is less effective. The consequence is that apparently timing truly matters if we want to combine these modalities in a meaningful way. And sequential treatment seems to be superior to concurrent treatment, unless in the future we manage to regard lymph nodes more as organs at risk than as primary radiation targets, as we have been doing so far. So it could be that the future needs us to reduce the dose to lymph nodes in a very deliberate way. So with that in mind, I would like to consider with you how these principles might be translated into new radiotherapeutical concepts in the area of borderline resectable, but also even resectable stage 3 disease, as this field is evolving. You all know the chemoimmunotherapy trials, which we will also be discussing later, where we learned that if we induce operable patients with combined systemic therapy, about 1 in 5 of these patients achieves pathological complete response, PCR, and those patients who then undergo successful surgery have a very favorable 3-year disease-free survival of around 65%. Now, as a radiation oncologist, we of course are very pleased to see these excellent outcomes, but at the same time, it's also a little painful to be watching from the sidelines, especially in upfront resectable tumors, having for a very long time been one of the key players in stage 3 disease. However, I would argue that the role of radiotherapy in stage 3 disease is still a crucial one, and that on the contrary, it might become even more important over the next years. And I would like to illustrate this with some exciting new data from the phase 2 stage, which suggests that even in patients who receive multimodal induction, adding radiotherapy, be it in the resectable or the borderline resectable setting, may take an already effective systemic therapy to the next level. And that depends very much on the intended use case. So the INCREASE trial from the Netherlands treated very advanced tumors with an intensive induction approach, essentially near full dose concurrent chemoradiotherapy combined with dual immunotherapy. The remission rates were outstanding. Roughly 2/3 of patients achieved a pathological complete response, which is almost 3 times as much with the chemoimmunotherapy induction alone. And the major pathological response rate was around 80%. However, this came at the cost of relevant toxicity. So yes, downstaging with radiotherapy does work, but it comes at a price, and it's certainly not the right strategy for every patient, but for selected patients. At the other end of the spectrum, we have data such as those from the Section 1 trial, which delivered a highly de-escalated radiotherapy approach in combination with chemoimmunotherapy induction. More specifically, this consisted of 3 × 8 gray SBRT delivered to the primary tumor only, explicitly sparing even heavily involved thoracic lymph nodes. And interestingly, the PCR rate and the MPR rate, they were almost as high as an INCREASE, but with clearly less toxicity. And what is particularly intriguing is that an abscopal response was observed in non-irradiated lymph nodes. So here it is again, the synergy between radiotherapy and immunotherapy that we have been talking about for so long, but in this case, conceptualized in a completely different way. Whether this advantage or this effect will also translate into improved disease-free survival is still something that needs to be validated in the next steps. And I'm very pleased that here in Germany, we came up with an intergroup effort, which we named the Focus Prime trial. And this study tests exactly this concept. It randomizes patients receiving standard of care neoadjuvant chemoimmunotherapy to either standard treatment alone or additional stereotactic radiotherapy of the primary tumor, 3 × 8 gray. And in the phase 2 part, we initially observe a PCR rate. And if that result is positive, then the phase 3 part will evaluate the effect on disease-free survival. And we are very pleased that this study is expected to begin recruitment this year, and we're looking forward to hopefully very exciting results. Finally, I would like to address one trial that had the aim of specifically looking at borderline resectable patients, and this is the MDT Bridge trial. So patients with resectable or potentially resectable tumors received chemoimmunotherapy induction and were then re-evaluated for resectability by the MDT. And if they had converted to resectable status based on their response, they underwent resection, and those who remained unresectable received definitive chemoradiotherapy followed by immunotherapy. The interim analysis showed something very interesting. So despite all the concerns that we have been voicing in guideline committees and interdisciplinary discussions regarding the application of those concepts outside of clinical trials, which quite honestly is being, it's my feeling and the feeling of my colleagues, is being done quite frequently, and I think it should be done only within clinical trials, because the studies that established chemoimmunotherapy induction, and we will get to that later today, were designed only for resectable patients, not for potentially resectable patients. But all these concerns put aside, we see a very interesting signal here, and this is the fact that among the small group of potentially resectable patients, and those were 28 at the beginning, that the majority, namely 23 patients, were converted to a resectable status. So, of course, there are important limitations to this trial. Overall, the number of patients was quite low. The criteria for resectable versus borderline resectable were not as clearly defined as one might have wished. And also the rate of treatment discontinuation for any curative treatment among those patients that failed resectability in the end was uncomfortably high, and that was roughly a third. So that's very much higher than treatment discontinuations if we had treated these patients with chemoradiotherapy up front. We, of course, have to give the study group the benefit of the doubt here, since this is an interim analysis, but especially this figure will have to be double-checked once definitive results are published. But despite these limitations, the results are very interesting, and the approach taken here, I think, certainly deserves to be explored in greater detail in future studies. So I hope I have been able to show you that through a deliberate and thoughtful use of radiotherapy in combination with immunotherapy, it is still possible to achieve synergistic and forward-looking effects. And I think we all look forward to achieving more together in the future. And I thank you very much for your attention.
Thanks a lot for this comprehensive overview and presenting, of course, the radiation oncologist's perspective. So we're looking forward to Alex Brunelli's presentation showing us the surgical view on this topic.
So thank you very much, Clemens. I was fascinated by your lecture, Ramie. I have also a couple of questions, but please remember me at the end of the session.
Definitely, thank you.
So I also slightly modified the title, and being the only surgeon, I wanted to bring the surgeon point of view, not only the functional part, but in terms of resectability. These are my disclosure. So as we have seen before, obviously the treatment landscape in the early stage non-small cell lung cancer is rapidly evolving due to the publication and implementation of the recent different trials in the different space, adjuvant, neoadjuvant, perioperative, in terms of immunotherapy, but also targeted treatment. So this space is rapidly changing, and more changes are expected, as we have seen in the previous talk. I will focus on the surgical trials. The surgical trials including neoadjuvant or perioperative chemoimmunotherapy treatment in the stage 3 disease. You see here, this is a summary of stage 3A, 3B, and there is obviously a good rewarding hazard ratio for event-free survival, disease-free survival in both stage 3A and 3B in all trials. I try to summarize, although this is not, let's say, a recommended practice, but to put head-to-head the results of the different, the main results of the different trials in terms of attrition to surgeries, for instance, which is extremely variable, from 7% to 22% in the Checkmate 77. In terms of R0 resection, from 83% in the Checkmate 816 to 95% in the Aegean. And the obviously major pathologic response and complete pathologic response in the intention to treat population, but complete pathologic response varying from 17% to 25%, depending on the trials. We recently published, and Clemens was among the centers, this real-world European study, including patients undergoing neoadjuvant chemo-nivolumab from 6 centers in Europe. This is a real clinical practice analysis, including patient stage 2 to 3B resectable. And we were able to analyze 340 patients who started the neoadjuvant treatment in real life with an attrition rate of about 7.4%. And the majority of the attrition rate is explained by toxicity or poor performance status after or during the neoadjuvant treatment, 9 patients for cancer progression. So the other interesting aspect in this real-world analysis, which differ from the trials, is that about half of the patients had surgery more than the recommended 6 weeks from the last neoadjuvant chemoimmunotherapy cycle. And the results of the European real-world study were slightly different also in terms of surgical procedure. You see here we had only about 4.4% of pneumonectomies compared to the nivolumab arm of Checkmate 816, 17%. The majority of the most frequent operation was lobectomy. The other large difference was the proportion of patients who started minimal invasive, 66% in our European series, compared to only 30% in the Checkmate. Slightly higher conversion rate, 18%, which perhaps means that there is a lower threshold for conversion, and the majority of conversion were due to difficult dissection due to adhesion or scarred hilar tissue, and not as much as for major bleeding. And you see here also the difference in terms of length of stay, which was much shorter in the European real-world series. On the other hand, the major pathologic response and complete pathologic response were similar to what reported in the trial, with a much higher R0 resection rate in our real-world analysis. So overall, the results from the trial are replicable or sometimes even better in the real-world practice in Europe. Even when breaking down the results by categories, subgroups, you see that the complete pathologic response and major pathologic response are similar by stage. So there is not much difference between stage 2 and stage 3B. And most importantly, by nodal stage, Even in clinical stage N0, there is a 24% complete pathologic response. And even more importantly, especially when discussing resectability, there is not much difference in N2 patients between single station and multi-station N2, which kind of break a dogma in our MDTs that multi-station N2 before chemoimmunotherapy were mostly considered unresectable. But you see here, now this has completely changed. The major pathologic response in this category was 66% with a 31% of complete pathologic response. Even the PD-L1 expression, just want to remember that, for instance, there is a slight difference from UK to the rest of Europe in terms of licensing of the nivolumab in this case, but or even other immunotherapy agent in England. We basically can administer neoadjuvant immunotherapy to all comers PD-L1 level, so even for those without PD-L1 or PD-L1 less than 1%. But you see here, even for those PD-L1 less than 1%, the complete pathologic response was 34%. Now, in our study, I think the other important aspect, besides the complete pathologic response or major pathologic response, we are very much obsessed by these two parameters. But I think another important aspect to take into consideration in the trials and in the real world analysis is the downstaging or the tumor penetration proportion. In our real world analysis, the nodal downstaging from node positive to node negative was about nearly 70%, and the overall downstaging in terms of TNM was 66%. So the majority of patients present a downstaging. I think this is very important when we discuss resectability, and this may change our mentality or mindset when we see borderline resectable cases and discuss these cases at the MDT. This is impress, but finally, almost at the end, is the EORTC resectability definition, which are consensus definitions for stage 3 non-small cell lung cancer, which have been proposed through a very complex and elaborated process, but for standardize the inclusion criteria for trials. And trying to overcome the limitation we have discussed before, where in most of the trials, when we read the inclusion criteria resectable or unresectable, we are not very much sure what the authors mean for resectable or unresectable. So I think the effort here is to standardize the resectability for future trials. And most of these categories make sense, as you see here. But obviously, there are categories which are clearly mostly unresectable. Some categories, they warrant an individual case discussion, like the multi-station non-bulky N2. And for bulky or invasive N2, both in stage 3A or 3B, they should be the topic of future research. At the moment, in the clinical space, they are mostly considered obviously unresectable. We recently proposed this survey to surgeons and oncologists, asking the clinicians to think as they were the patients. So if you, as a doctor, were diagnosed with the locally advanced non-small cell lung cancer with different permutation in stage or PD-L1 level or even driver mutation, which management or treatment would you prefer on yourself? And it's very interesting to see here that there is still a great variation in preferences and differences between oncologist and surgeon. Look, for instance, at the stage 3B without driver mutation, PD-L1 90%. The majority of the oncologists still preferred chemoradiation and immunotherapy, the Pacific trials. Surgeons, clearly, they preferred a neoadjuvant or perioperative approach, including surgery. But even if you go down by stage, in stage 3A, like T1, T2, and 2, there is still a difference in oncologists and surgeons. 1/3 of the oncologists, even for this stage, would prefer the Pacific trial on themselves rather than any form of neoadjuvant or perioperative chemo, IO, and surgery. So we have discussed briefly about N2 disease. There are different guidelines. More or less, they explicitly state that fit patients, single station N2, not requiring a pneumonectomy. They all recommend systemic anti-cancer treatment, including immunotherapy, and then, if eligible, and then surgery. The proportion of N2 disease in the different trials range from 35 to 72%, so a large proportion. But also, I think it's interesting to notice that the proportion of multi-station N2 was quite high, up to 40% in some trials, surgical trials. These are neoadjuvant, perioperative, or adjuvant trials. And I found this review or meta-analysis, although limited to only 3 randomized trials of neoadjuvant or perioperative chemoimmunotherapy, very interesting, because it shows, as we have shown in the real world study, that even for N2 multiple station, in the era of chemoimmunotherapy, the results in terms of event-free survival are similar to single station N2. So there is no justification in excluding these patients from the neoadjuvant chemoimmunotherapy regimen if otherwise resectable. And this is what we have found in our European study, as shown before. This is just a graphical representation. So multi-station complete pathologic response is similar, if not slightly better than a single station. We still don't have, obviously, the long-term follow-up, because this is a very recent analysis, not mature, to see whether this translates in event-free survival. So we have discussed about the downstaging, the major pathologic response. So can then we use immunotherapy to convert to surgery what is unresectable, or initially deemed unresectable or borderline resectable? I appreciate that all trials state clearly, and also in the licensing and reimbursement criteria, that a patient or a tumor need to be resectable up front to be eligible for neoadjuvant chemoimmunotherapy. But considering what we have seen before, I think there is space for using chemoimmunotherapy in a more flexible way. We can discuss this obviously in the discussion, and this is something that we have started to do gradually in our MDT in Leeds. But you see here, I think this is quite interesting and quite recent, a group of borderline or resectable or unresectable stage 3 non-small cell lung cancer treated with chemo IO. 75% of these patients proceeded to surgery, and you see the change of stage here. 100% of clinical stage 3C, which are the N3 disease, were downstaged. 81% of the 3B were downstage. So I think it's very important, with all the limitation of this study, of course, to take this into account together with the high proportion of downstaged patients we see in the even in the group of resectable patients included in the trial. This is another recent paper of a large group, about 500 stage 3 unresectable, and basically 59% of these patients after induction chemoimmunotherapy were made basically resectable. They had a 70% rate of minimal invasive approach, only 4% conversion rate, and the complete pathologic response in this group was 36% with minimal 90-day mortality. They had a 61% of stage 3B and even 5% of stage 3C. So quite interesting results. I don't want to spend too much time in the discussing the MDT bridge, which has been discussed before. Just to emphasize again that about 87% of these patients initially borderline resectable were then proceeded then to surgery. Anyway, 95% had some form of curative treatment after neoadjuvant chemoimmunotherapy. And this is a LungMate 013, another similar induction trial. Basically, patients with unresectable stage 3B, 3C non-small cell lung cancer received induction chemo IO, and then the resectable, those patients who became resectable, 57%, were randomized in radiotherapy and surgery. Those who received surgery had the complete pathologic response of 48%, so quite good results. So what I wanted to say is that perhaps in this new era of immunotherapy, with immunotherapy and rediscussion of the MDT, we can perhaps redefine resectability in locally advanced non-small cell lung cancer in a more flexible and response-guided way. So we are transforming the rigid criteria basically to tailored curative option in non-small cell lung cancer. I just want to finish with a few slides regarding fitness assessment before surgery. So do we need to reassess fitness for surgery after neoadjuvant treatment? This is what the new ERS-ESTS guidelines suggest. So they suggest to repeat preoperative pulmonary function testing after completion of the neoadjuvant treatment to redefine the surgical risk. And this basically is explained by several studies, even showing structural lung damage after chemotherapy. It's not just an effect of immunotherapy, but mostly of chemotherapy. It's well known that these patients may actually have a structural damage, which explain a decline, especially in the LCO, more than FEV1, a decline of about between 10 and 13% from the pre-treatment value. This is what has been observed in a few studies. For instance, this very recent study in the JTCVS with a median DLCO change of 11% and an association an increase in postoperative pulmonary morbidity of 2.2 folds in those with impaired DLCO. So we need to be very careful in reevaluate these patients after neoadjuvant chemoimmunotherapy. Obviously, then we can discuss what should we do if we find a decline of such an extent, which is associated with increased risk of postoperative pulmonary morbidity. This is also what we have found here in Leeds in about 100 patients, more than 100 patients from April 2023. Basically, the median post-chemo IO drop was again 11%, which is quite consistent in all papers, with a large drop greater than 18% in 25% of patients. The only difference we found is that this group had a much higher attrition rate, about 20%, compared to those without this large drop. And this might take on messages which are basically summarizing what we have discussed, and then I hope we'll discuss further at the end of the webinar. Thank you very much for your attention.
Yeah, thank you, Alex, for presenting the surgical perspective in this rapidly evolving field. And so finally, we're very much looking forward to hear from Kristof Cuppens, the medical oncologist's view on this area. You're still muted.
Can you see my screen?
Yes.
Okay. So good evening, everybody. Thank you to Clemens for the kind introduction. I also slightly adapted my title like the previous speakers, but just a minor thing. I removed the medical part of the oncologist because I'm a thoracic oncologist, which means that I'm a pulmonologist and an oncologist and not a medical oncologist, which is also my major disclosure for this talk. So as discussed by the previous speakers, we all know that early stage non-small cell lung cancer can be treated in a curative intent, but there's a high risk of recurrence, and immunotherapy has the potency to improve the cure rate for these patients. So we know that patients with a stage 1 have more than 80% survival, and as soon as the tumor size increases or there's nodal involvement, this prognosis drops to less than 50% in stage 3A patients. So there's a number of strategies that we can uphold when we look at our early stage non-small cell patients. So first of all, you have to start with a very adequate pre-surgical staging, and then based upon that staging, we're able to classify our patients in two major groups: patients that have a low risk of recurrence or patients that have a high risk of recurrence. Patients with a low risk of recurrence are excellent candidates to move towards directly a surgical approach. But even in these cases, we not infrequently note post-surgical upstaging due to, for example, unforeseen nodal involvement, then leading to the introduction of an adjuvant therapy, chemotherapy with or without immunotherapy. And then patients that are identified as being at a high risk of recurrence from baseline can either be treated still with upfront surgery followed by an adjuvant therapy, but as also stated by the previous speakers, there's a shift towards a more neoadjuvant approach with neoadjuvant chemo and immunotherapy followed by surgery, followed by an adjuvant continuation of the PD-1 inhibitor or not. So in patients that have a baseline irresectable disease, chemoradiotherapy is the preferred approach, either concurrent or sequential based upon patient fitness on potential comorbidities, and then followed by consolidation durvalumab, also based on tumor biology, for example, the presence of an actionable genomic alteration, the PD-L1 score, or also the presence of a comorbidity not allowing the safe use of an immune checkpoint inhibitor. So I'm going through some of the landmark trials within these possible strategies, and some of them have already been alluded on by the previous speakers, for which my apologies. One of them is the adjuvant atezolizumab trials for patients that had a R0 resection that are at an increased risk of relapse, that received 1 year of atezolizumab compared to best supportive care after the adjuvant chemotherapy. This led to the improvement in the disease-free survival in these patients. In the patient group with the highest risk of recurrence with PD-L1 expression, this benefit was the most pronounced. And in the all-comer population and all-comer PD-L1 population, this effect became less strong, but still had a positive effect on the disease-free survival. However, if we look at overall survival in this study, in the ITT population, all-comer population, all-comer PD-L1, there's no benefit of adjuvant atezolizumab, and it's only in the group with the highest risk of recurrence, with the highest susceptibility for PD-1 inhibition, so the PD-L1 more than 50% of patients, that a survival benefit was noted. So the adjuvant strategy has proven some benefit, but it's not as, let's say, as impressive as we see with the neoadjuvant approach. And in the neoadjuvant approach, this is probably the most cited, one of the most cited studies, the CheckMate 816, evaluating chemotherapy combined with nivolumab or placebo in a solely neoadjuvant regimen. This is also the only study that is evaluating a purely neoadjuvant regimen. All the other major RCTs that have been published are perioperative regimens. And the primary endpoint of this study was to evaluate the increase in pathological complete response rate. That was a very positive result, with 24% of complete pathological responses in the experimental arm compared to only 2% in our chemotherapy, making us wonder, what have we done all these years before with our neoadjuvant chemotherapy? This led to an improvement in both event-free and overall survival. And this survival benefit is mainly driven by patients achieving a pathological response. So there's a clearly improved overall survival if we look at the all-comer population. But if you split it up for patients achieving a pathological response, you can see that patients achieving a pathological response, whether this is with chemotherapy or with chemoimmunotherapy, they have an excellent survival. And when you compare it with patients not achieving a pathological complete response, you see that the survival rates drop to approximately 55% on 5 years. And there's no major difference whether this was with patients pre-treated with chemotherapy or chemotherapy plus nivolumab. So if we combine both approaches with the neoadjuvant and adjuvant, then we have a perioperative regimen. This is the KEYNOTE-671, evaluating chemotherapy plus pembrolizumab or placebo, and post-operative continuation of the pembrolizumab or placebo. So this study had a significant result with an improved overall survival at the second interim analysis, which was clinically and statistically significant. Also in this study, the PCR patients, so patients achieving a pathological response, are the ones responsible for the main effect on the survival. Although if we look in this study at patients not achieving a pathological complete response, there appears to be a difference between those receiving pembrolizumab or no pembrolizumab in favor of pembrolizumab continuation. There's one major caveat with this study is that there was only one time point of randomization at the beginning of the study, and no second randomization took place post-surgery between placebo or pembrolizumab for the different pathological response subgroups, which would have been the most ideal scenario to finally end that discussion. Also discussed before, the Pacific trial of durvalumab versus placebo consolidation after concurrent chemoradiotherapy for patients with an irresectable disease, clearly resulting in an improved progression-free and overall survival, leading to the adoption of this regimen as a standard of care for patients treated with chemoradiotherapy. So in general, immunotherapy has broadened our treatment options for patients with both resectable and unresectable disease. However, now we get to the more philosophical part of my talk, and I get some liberty on freewheeling. What is a truly resectable or irresectable disease? So my 2 cents as a thoracic oncologist would be that a resectable disease is a disease in which a primary resection has a very high probability of an R0 resection, meaning that both tumor margins and lymph nodes are cleared, resulting, of course, in an improved long-term oncological outcome to any other treatment. And an irresectable disease is the condition in which these premises cannot be met, and other therapeutic regimens are favored to improve the outcome. So, when we look at all the neo and peri-adjuvant studies that has been done, and it's very rightfully so already remarked before that all these studies were done in patients that were identified as a primary resectable disease. And these were defined as per multidisciplinary tumor board. So these trials, all the previously mentioned trials, all the perioperative trials, they were not designed to evaluate whether a resectable disease can be transformed, an irresectable disease can be transformed in a resectable disease. Also, stage 3 is a very heterogeneous disease. So we don't have, let's say, sufficient granularity in the data that has been published so far. These are 2 images of a stage 3 patient. On the left, a patient with a very bulky N2, which we considered as irresectable, that was treated with chemoradiotherapy and adjuvant IO. The second patient was a patient with a very small primary tumor and a single lymph node at 4 right, that was treated with neoadjuvant chemo IO and then surgery. So what we also know is that if we try to find some consensus on what is a resectable or unresectable disease, then this EORTC questionnaire that was held with different experts, both surgeons, pulmonologists, oncologists, radiotherapists, is that the only consensus is that there is no consensus on a large portion of diseases, whether or not they are considered resectable. So if we're not even clear on what is the definition of a resectable or an unresectable disease, how are we going to define what an unresectable disease, borderline resectable disease is? So a borderline resectable disease, as I see it, is an irresectable disease that can be transformed to a resectable disease after a successful treatment. And this is a strategy that has been used in the past by, let's say, more and no offense to anybody who participated in these trials, but more historic trials looking at neoadjuvant chemoradiotherapy, for example, for sulcus superior tumors or N2 diseases, also resulting in expert centers in good end results. So borderline resectability can be defined anatomically, functionally, or oncologically. Anatomically are the cases with a high risk of not achieving an R0 resection. It can also be functionally determined. We can have patients that have pulmonary reserves that are limited, that do not allow them for example, a pneumonectomy, but they would be able to undergo a lobectomy. And in case of a successful downstaging, it might be that a patient can still undergo surgery. And then oncologically, and that's probably the most controversial part of the borderline disease, is the extent of disease that has a high risk of recurrence. If we were able to predict the patients that would have a complete pathological response, then we could even look at broadening the cases that we are going to treat based on the N status, and even looking at N2 or N3 disease. So there's a lack of consensus definition on what a borderline resectable disease is, and there is limited prospective data. But we know that through the, let's say, by proxy metrics from all the studies that have been done, that there are very good options. You can see that across all the perioperative trials, there are very significant pathological complete response rates, but also the MPR rates that are quite high. So there is a significant number of patients that are being downstaged to YPT0N0. And also, if we look at the nodal evolution data, for example, from the Checkmate 77T, which is probably the study which had the most complete nodal data, you can see that downstaging to YPN0 occurs in just under half of the patients in this study. So can borderline resectable disease be converted in resectable disease? And I'm afraid I'm going to be a bit repetitive, as the previous two speakers also alluded on the MDT Bridge study. So I'll put my 2 cents with this study. So as said, it's a neoadjuvant study looking at multidisciplinary reassessment at several periods. 2 cycles of durvalumab plus chemotherapy, then followed by reassessment in patients with stage 2B, 3B resectable or borderline resectable. And the primary endpoint is the resection rate, which is important to note in this study. And this swanky plot was shown also before. So very high proportion of patients that underwent definitive resection, and a very high proportion of patients, 80 out of 84, that had sufficient follow-up, were able to receive a definitive treatment, either surgery or chemoradiotherapy. And in this study, there's a quite important expansion of the resectable cohort. 23 out of 28 of the resectable, deemed borderline resectable patients were reassessed as resectable at the second MDT reassessment. And what is important is to note that the conversion to a resectable disease appears to be feasible in case of a successful response. So objective responses were far more frequent in patients that were reassessed as resectable after 2 cycles of neoadjuvant immunochemotherapy. And also a significant proportion of patients that were deemed resectable at reassessment in the end achieved pathological complete response with more than 27%. The overall resection rate, which was the primary endpoint of the study, was 85.7% R0 resections. And if we look at the patient group that was baseline resectable, then 92.9%, which is impressive high, had an R0 resection. But if we look at the baseline borderline resectable, we see that approximately 71% of the patients had an R0 resection. So there does appear to be a difference in completeness of resection in patients that were either deemed baseline resectable or borderline resectable. Also, Ramie already alluded on this. There's a proportion of patients that did not make it to surgery that went on with chemoradiotherapy. In this study, we still lack follow-up to assess the long-term safety and efficacy in these patients, but it's a very small patient group, so it's doubtful that we will have very useful data on it. But also we lack the granularity on the 4 patients that were discontinued in this protocol and see what happened here. Although, in all honesty, if we also look at chemoimmunotherapy neoadjuvant or perioperative studies, there's also a number of dropouts for surgery for various reasons, which are often also just linked to the typical clinical trial setting with lost our follow-up or no longer giving consent to participate in the study. So is conversion strategy for borderline resectable disease ready for prime time? So that's the major question, and it's only now at my last slide that I end up with my title slide again, to the title of the talk. So my perspective, or the oncologist's perspective, on the systemic treatment in borderline resectable patients. I think that immune checkpoint inhibitor-based therapy is indispensable for patients with a resectable, non-AGA, early-stage non-small cell lung cancer with a high risk of recurrence in order to improve the cure rate. Also, these immunotherapy-based therapies combined with chemotherapy appear to be able to convert borderline resectable to borderline resectable or irresectable disease to resectable disease. However, as said, there's no clear definition of what a borderline resectable disease is. There's still some controversy on that. The specialist MDT decision is central in all these studies that have been done and published. So which makes me wonder, how do we translate to non-specialist MDTs or hospitals with lesser experience in treating these kind of patients? There's a potentially lower rate of R0 resections when we do this strategy. So, and there's limited randomized or mature data on safety and efficacy of the chemoradiotherapy after neoadjuvant ICI. And so far, as Ramie already showed, also is the signals aren't that optimistic. And also, do we truly need to go towards surgery in these patients? There are no, or not by my knowledge, studies evaluating the superiority of a conversion strategy to chemoradiotherapy followed by ICI in these borderline resectable patient group. So my 2 cents is, are we ready for prime time yet? I don't believe we are for the general population. I think we will have to be very, very strict in which patients we select, but I am confident that there are patients that will benefit with this strategy, and we will definitely need more prospective data to better inform our decision in the future. I thank you for your attention.
Yeah, thank you, Kristof, for the overview and for the nice summary. We're a bit over time, but nonetheless, we'll proceed with the discussion. So please ask your questions in the chat. So let me start with an issue. All 3 of you mentioned the MTD bridge trial. And we've heard a lot about the difficulties in defining borderline resectable disease, and I think it's a huge effort that the EORTC came up with consensus definition that's going to be published now. In the MTD bridge, a lot of those borderline resectable patients became resectable. So do we have any idea how this resectability after neoadjuvant should be defined, or do you think this should be based, like the RTC recommendation, mainly on the oncological criteria? Is there any, should the dynamics be involved? What about the restaging that should be done? What's your take on this, what we have available in data, and what probably could lead us to a more refined idea of how to handle that?
Well, if I can just say something, I think the EORTC definitions is a broad guide, and is more for standardization of trial inclusion, and certainly not something that we can strictly use in our tumor boards, to rigidly classify patients as resectable or not. As always, I think we need to assess the patient individually, even after, and even more critically after, an induction, treatment, from a resectable, borderline resectable. For me, resectability means that the surgeon will be able to completely ensure R0 resection. If this is not feasible, this is not resectable. It is clear that this includes lymph nodes as well. Restaging, the question of restaging is, I think, for borderline or previously unresectable, I think is important. We normally don't restage invasively the mediastinum after neoadjuvant chemo-IO in resectable cases, unless we have a suspicion of progression or M3 disease. But you have seen clearly that in those studies of borderline resectable or resectable, they also included M3 disease, and this clearly need to be ruled out before embarking in surgery, I think.
So if I may add something to that, I totally agree. In addition, I think it's very important to collect these data in the form of prospective trial, because at the moment, I mean, we tend to disagree on what's resectable and borderline resectable up front. Now, when we come to the point of a pre-treated patient, we're even more unsure, because we don't have any clear methods of quantifying the response, of with enough certainty tell if this patient has responded to the treatment, or what we see in the imaging is maybe a reactive PET uptake or reactive fibrosis. So here I would say we're basically ballparking this, and the MDT bridge trial is certainly the first and very important step to look at that. But we will need a lot more data and a lot more quantitative data, because MDT bridge said the MDT can decide, and we know that this can differ hugely between centers, and there are no strict criteria. So all these points together, I would say, add to the fact that we need to look at that within prospective trials and assess it very systematically, and maybe also look at the biomarker side of things to develop new indicators to identify the patients who have responded to induction treatment, and be able to tell that with more certainty down the line.
I agree.
Yeah, absolutely. And it's the call for biomarkers again, and adequate ways to evaluate which patients have responded and which are the patients that will benefit for a more radical approach. Because if you see approximately 1 out of 4 patients has a pathological complete response, but this still means that about 3 out of 4 does not have a pathological complete response, and these are type of tumors that I'm worried about, because they appear to be biologically very resistant to what we are doing, and the question is, what we are doing currently, is that the best what we can offer for these patients? I doubt it. I think that we will need different treatment strategies and I do believe, for example, in the approach in which radiotherapy is being combined, for a certain proportion of patients that have this more refractory character, that might be a way to improve the pathological complete response rate. But also we have to look at combination strategies with novel ICIs in order to improve the response rate for these patients. And ideally, that would be biomarker-driven therapy choice, but yeah, we're nearly nowhere on achieving that.
Can I ask a question to Ramie? You know, because I was fascinated by the discussion about limiting treatment or sparing treatment to lymph node to preserve the immunocompetency of the lymph node. Can we translate this to surgery? This is a always very hot topic, the extent of lymphadenectomy, because there have been some report, and even, you know, in the lab, that, you know, an extensive lymphadenectomy may be associated, in the context of immunotherapy, can be associated actually with a reduced immunoresponse. So do we, as surgeons, do we still need to perform an extensive lymphadenectomy after neoadjuvant chemoimmunotherapy? This is, I'm asking to you, asking to myself and everyone. Because, you know, you can translate, right, this to the surgical arena.
It's a very, very interesting thought that honestly hasn't occurred to me so far, because, you know, we're always, when we talk about radiotherapy and immunocompetent cells, we're always focused on dose and on the biology behind it. And so what we've learned is that it's an aspect of timing, it's an aspect of dose, and it's an aspect of radiation volume. Of course, when you remove all these lymph nodes, you might as well have the same effect, which is a very interesting take on that. I think the timing matters as well. So if during the neoadjuvant phase, the immunotherapy has enough time to perform this lymphocyte priming, and you have enough tumor antigens to prime the lymphocytes, then I think it becomes a little less relevant, because then they, you know, spread throughout the body and do their work, and they're not confined to the lymph nodes as much anymore. So I think the timing aspect is relevant. That would be my personal hypothesis. But on the topic of the extent of lymphadenectomy, and please correct me if I'm wrong, but my feeling was that if patients do not respond, or maybe respond only partly and achieve a partial response, then most of the time the vital residual tumor is not in the lymph nodes, it's mostly the primary, right? So I think that is the place of most resistance, and that we should be most worried about. And for radiotherapy, that has been my hypothesis for quite some time. It would be very interesting to see if we have a similar effect with surgery. Very interesting, especially if we think to continue in the perioperative, so in the adjuvant immunotherapy. So perhaps you want to leave some lymph nodes.
But if you look at the adjuvant data, the adjuvant IO data, they're a lot less impressive than the neoadjuvant. And one of the hypotheses is that the absence of a functional lymph node apparatus, and also the absence of sufficient antigenic leverage, leads to the fact that the effect is less. So it's circumstantial, but yeah, also in the adjuvant treatment settings, you see a bit the same result.
Yeah, I think that's a discussion that could be continued for a long time, and there are a lot of questions open. So it's really an evolving and highly dynamic field. Nonetheless, we're unfortunately quite over time already, so we have to stop here for today. I'd like to thank all three of you for your excellent presentations and for the good discussion, and also the participants for spending their time with us. And I'd also like to point out our next webinar, which will take place on April 13th, and will cover the topic of training in thoracic surgery, and certainly is of major interest for our residents also in the audience. Thanks a lot for today, and see you soon.